Hi, it's Cindy. Let's finish up the digestive system with part 2. Next thing we'll talk about is the treatment of hemorrhoids. There are several codes that are characterized by how the hemorrhoids are eliminated. The first one is excision, where a clot and the diseased tissue is removed all in one piece. Then there's a rubber band ligation, also called banding. And that banding code is the same regardless of how many hemorrhoids the physician bands in a single session. A suture ligation is when the physician ties a suture to the base of the hemorrhoids, which is going to cut off the blood supply. The documentation that's provided to you has to tell you what is ligated during the session. And then hemorrhoidectomy is when they're actually removed, excised, and that's differentiated by whether the hemorrhoids were internal, external, or both, and by the number of columns or groups, single and multiple. There's also destruction of internal hemorrhoids by thermal energy, which includes cautery, radiofrequency, and infrared coagulation, and destruction by cryosurgery. Now, we are instructed to use an unlisted code. I've never coded destruction by cryosurgery, but that's why we have those unlisted codes, so that if we ever are in a position to have to code that, that's what we are told to use. That's the benefit of guidelines. They tell us what to do when we don't know what to do. Percutaneous biliary procedures involve the liver, the gallbladder, and the bile ducts, and we did see some diagrams in part 1, so hopefully that is familiar to you now. And these codes are going to focus on the placement and the subsequent removal or the exchange of those stents or the catheters for biliary drainage. An example that's given is a transhepatic cholangiogram that is performed percutaneously. And in this procedure, imaging guidance is included in the code. So we want to be sure whenever we are reading anything about biliary and percutaneous where a radiologist is going to use the images to know where he wants to put that catheter or that drainage tube. In this particular one, the percutaneous transhepatic cholangiogram, imaging guidance is included in the code, and the radiologist is using that guidance to place the tube through the skin, which is an external approach, into one of the ducts in the liver to allow the bile to drain. If you're wondering why would you do that, well, for some reason that bile duct is not working correctly. Either it's something congenital. I know someone that was born with problems with bile ducts. It can also be an obstruction due to a stone or disease. And here we go, back to another anatomy lesson. This one just has additional tubes coming off where you can see the different ducts coming off of there. And as I mentioned in a few slides ago, the placement of the biliary drains differentiates between external and internal external, and by new versus an existing access, and if the placement of a separate drainage catheter was necessary, like you have a stent and a catheter. So now we'll do exercise 428, number 4, the placement of an external biliary catheter, and you see that imaging guidance was used with the fluoroscopy. And the physician percutaneously places an external biliary catheter into the bile duct for drainage. And here is the pathway and the answer. Let's talk about cholecystectomy, which is the removal of the gallbladder. These codes are differentiated by with cholangiography, with exploration of the common duct, which is a bile duct, and a cholecystoenterostomy. We'll look at these individually. In a cholangiography, X-ray is performed using contrast dye, which allows the physician to see what exactly is going on, if there's a blockage, for whatever reason, what's causing it, what can be done about it. It just allows him to know what helps him to see what he wants to see. Whenever the physician chooses to explore the common bile duct, that is performed to see if something like a stone or some kind of cancer can be in ducts. something that's blocking the flow of bile from the liver to the intestine. If something is blocking the bile duct, that bile is going to back up into the liver and cause jaundice, which you may have seen, that very yellow skin, and even the whites of the eyes can become yellow. And then the bile duct can become infected and require emergency surgery if that stone or that blockage is not removed. So this procedure, this exploration of the common duct, can be done while the gallbladder is being removed. So that's why it's included as one of the things that can be completed during this procedure. Then the cholecystosclerostomy is an actual surgical anastomosis, or a connecting of the gallbladder and the intestine if the common bile duct is just not there. It's just not available for the body to use to transport the bile between the gallbladder and the intestine. So the physician or the surgeon anastomoses or connects the two body parts, the gallbladder and the intestine, and that includes connecting blood vessels, parts, anything that helps take over the function of the common bile duct. Our next exercise is 428, number 8, laparoscopic cholecystectomy with exploration of the common bile duct, and here is the procedure. Now let's talk about hernias. I chose this picture because it shows the approximate location of these different hernias. I don't think anyone would ever, hopefully, have all of those types of hernias on one body, but it does give you an idea. I have seen, too, the inguinal. My husband had an inguinal hernia, and his was definitely a little bit lower than the one that's shown here, but it gives you an idea of where these body parts are. The umbilical is just right around your belly button. Epigastric is just under your diaphragm. And then you see where the inguinal is in the groin area, as is the femoral hernia. So these terms describe the type and or the location of these different hernias. And they're also differentiated by whether the hernia is initial or they've had it before, it's recurrent, the age of the patient, and its clinical presentation. Now, the clinical presentation is one of those words that's going to occur after the semicolon, like we've talked about. Reducible is when the hernia can be returned to its normal position in the body by surgical manipulation. Slotting is when the colon or the cecum is part of the hernia sac. It's coming out of the body. Incarcerated means you're not going to reduce it without surgery. And strangulated is an emergency situation where the blood supply has been cut off. So that has to be attended to immediately. Types of hernia repair, you have the traditional, where the physician just pushes that bulging tissue back into the abdominal cavity and closes the hole with sutures. You have mesh, where the doctor puts a mesh over the hole and sutures that in place. The use of mesh is only reported when the physician is repairing an incisional or a ventral hernia. The use of mesh with any other hernia repair is not coded. There is an example of a laparoscopic hernia repair in figure 4.22 of the textbook. And the last type of repair is a paraesophageal hiatal hernia repair, where the codes are differentiated by the technique, whether it be a laparotomy, thoracotomy, or a thoraco-abdominal incision, and by whether mesh was implanted. So again, read in those code descriptions, being sure you're choosing the one you want to code. Our next exercise is 426, number 2, the laparoscopic repair of a recurrent incisional hernia. Recurrent means it's been repaired before, it's come back. Incisional is a type of hernia that occurs over where an incision took place. That was a previous operative procedure, and now the body is pushing tissue through that old incision site. And you see I have two codes that I've listed. I looked up two different things. I looked up the incisional recurrent and the incisional laparoscopic. So you have to go in and just read those and see which one works. And in our case, the 49656 is the correct code. The next exercise is recurrent of an incarcerated inguinal hernia with mesh. Remember the guideline we just read. If it's mesh with anything other than incisional or ventral, it is not coded. So we're only going to have one code more than likely, and it is 49521. The next exercise is initial repair of a strangulated ventral hernia, and remember that a strangulated hernia needs immediate surgery. Ventral requiring mesh, that is when the implantation of the mesh will be coded for the incisional and the ventral hernia repairs. And there we have the two codes, one for the strangulated hernia repair and one for the implantation of the mesh. I just wanted to put a couple of slides in here about gastric bypasses. I didn't see any thing in the textbook so much about it, and I thought we should at least talk about it a little bit. The gastric bypass is also called a Roux-en-Y, which is a gastroenterostomy. Roux-en-Y is just, it's the way it describes the procedure. You're cutting the stomach in two, and you're creating a pouch out of a small part of the stomach and attaching that to the small intestine. So you're bypassing a large part of the stomach, and that can be done laparoscopically. You see that long part coming down, that's referred to as the limb. So you will see some code distinctions that talk about the length of the limb. So just another thing to think about when you're reading those code descriptions. And here's the exercise from your textbook, 428, number 2. It's a laparoscopic gastric bypass in Roux-en-Y gastroenterostomy performed for obesity. That is included as part of the code description, so I think that's why they probably included it in this exercise. And there is the path as well as the code. Then this is a referral back to a procedure I talked about in part 1 with the aspiration of the ovarian cyst, and how strange that might seem to be in the digestive system section of the code book, but it is, because you're entering through the abdominal cavity to get to the ovarian cyst to aspirate it. So you would find it there. And here is the code. And the last code has to do with palatoplasty for a cleft palate. This particular one is a soft palate. And there is the code. Okay, that is the end of Chapter 4's Digestive System. If you have any questions, please post them in the discussion board along with the path that you have used to try to find the answer, and I will try to help you. Thanks so much and have a good day. Bye-bye.